to What's New with PCPCH. We are really excited to have some of the PCPCH program staff here to talk to us about the updates to the PCPCH standards. We definitely want to hear from the folks who are here today. There are 113 of you and growing. There were more than 200 people registered, so everyone is and will remain on mute for the duration of the presentation, but we definitely do want to hear your questions. So there's a questions pane in the GoToWebinar control panel. That's where you can submit those to me, and I will organize them and pose them to our presenters during time we have set aside at the end for Q&A. There's also, and you'll see this at the end of the presentation, an office hours spot scheduled in a couple of weeks that will be a chance for people to ask their specific questions. So you can sign up for that if you don't get a question answered today, or another question occurs to you between now and then. I'm thrilled to introduce our two presenters to you today. First is Dr. Evan Salino, who's a family physician in Portland, Oregon, at a safety net residency teaching clinic, where about half of the patients have private insurance and the other half are on Medicaid or are uninsured. In addition to seeing patients in the clinic, he works on a variety of health policy, advocacy, and communications issues with groups such as the Oregon Academy of Family Physicians, as well as with legislators in Oregon and nationally. Through his position at the Providence Center for Outcomes Research, Dr. Salino acts as the clinical advisor for the Patient-Centered Primary Care Home, or PCPCH program, working to bridge the gap between policy and practice. So we're going to hear a lot from him actually in that vein today. And then we have Chris Carrera, Improvement and Implementation Manager with the Oregon Health Authority. Chris has worked in healthcare since 1998 in roles including delivering direct patient care as an LPN and EMT, urgent care, emergency medicine, outpatient surgery. He was an epic analyst for oncology and ambulatory clinics and a quality improvement coordinator and also a clinic manager. He holds a Bachelor's of Science degree in healthcare management and a Master's in public administration. Before becoming the Improvement and Implementation Manager at OHA, which includes management of the PCPCH program, Chris served as a practice coach with the PCPCH team, which included conducting site visits and providing technical assistance to recognized PCPCH clinics throughout the state of Oregon. So we're definitely in good hands. What we hope to do today is learn how the PCPCH model is transitioning from 4 levels of designation to 5, understand how the existing 3-star designation is being replaced by the new 5-star designation, talk through the revisions to 12 of the existing patient-centered primary care home standards, so point out the differences between the current model and the model that clinics will attest to in 2017. And then receive information on the new must-pass measure. So there is one additional measure that has become must-pass in the new model. Also, before I turn things over to the presenters, let you know that in your control panel, you'll find a PDF of 2 documents. One is the slides from today, and the other is a document that captures the changes to those specific 12 that we're going to go through. And then also the session is being recorded, and a recording will be available on the website but by the end of the day today, and then everybody who's on today will get an email with a link to that. So you'll be able to share it with folks who couldn't be here. And so with that, I will hand things over to our presenters today.
Thank you, Kate. I appreciate the introductions and your hosting. Call it. Make sure we can advance the slide here. There we go. So, as Kate mentioned, we'll be speaking about the PCPCH program. So the purpose of the PCPCH program is to advance primary care in the state of Oregon, and we do that primarily through conducting site visits at our recognized clinics throughout the state of Oregon, and we're currently just a little over 630 recognized clinics, and also we provide technical assistance to these recognized clinics. If you noticed on the slide that we're on right now, it does say Transformation Center on there, so that is a recent development. Some of you may not know this, but the PCPCH program integrated with the Transformation Center here at OHA over the summer, and so we're very excited to be a part of that team now, and just wanted to make sure that everyone calling in knew that we are now part of the Transformation Center. But we're still PCPCH program and doing the work we've always done, but now we've partnered with the Transformation Center, and we're excited to be doing that. So I'll hand it over to Dr. Evan Salino here.
Hi there. Thanks a lot to everyone for joining. This is Evan Salino here. I just wanted to really briefly, as we're starting this, center us around the things that are most important, which is really the patient care that we give. We're going to be talking about, details of standards and measures and points and levels of designation and things like that, all of which are very important. But what is the most important thing is the ultimate goal, which is to improve patient care, to improve care for the folks that we take care of and the communities that we live in. And as you all may be aware, certainly calling into this webinar, Oregon's model of patient-centered primary care is focused around these 6 core attributes that are right in front of you here. These are evidence-based attributes of care that demonstrate that if patients are provided these things, they are healthier, they live longer, the healthcare costs that they accrue are less. So, we start with accessible care. We start with access as the place where patients start, right? So they're at home, they need some help, they have some questions, they need to access somebody to help them. So that's where we start. That's that front door there that you see. And that's where patients come in. We have them come in for appointments or phone calls. We talk to them on the phone, emails, things like that. Once they're in our clinic, we want to really give them the best care possible, the most evidence-based, highest quality care possible. That's really the accountable care, accountability, being accountable for the care that we give, understanding how are we doing in terms of giving that care. We're all well trained, we all want to do the right things, but how are we doing for our patients who have issues or illnesses, or we want to give preventive care? Are we doing a really good job of that, and how can we do better? That's what the accountable care is about. In primary care, certainly we don't see people as an organ or an illness. We see them as a whole person, as a comprehensive person in their communities, in their families. And so that comprehensive attribute is very important as really the scope of care that we give in primary care that includes things like preventive care, like screening and thinking about mental health issues, substance abuse issues, developmental issues, other health risks that are important. And then, when patients are not with us, when they're getting care other places, we take care of them over time. We take care of them over space. So we give them care that is continuous. Continuity is very important. And that's actually one of the most evidence-based parts of primary care is continuous or continuity care. And then we want to give them care that is well coordinated. So then if they're seeing specialists or seen in the hospital, or they're not with us, they're not coming in for appointments, but we really want to make sure we're keeping track of the tests or preventive care that they need, we're thinking about them when they're not with us. And that is coordinated care. We're working together with other folks to really coordinate their care. And the last, but maybe most important part is the roof there, that patient and family-centered care, right? This is the patient-centered primary care home program. And, engaging folks in ways that to help them understand their health issues better, in ways that they understand, giving them tools to understand their issues and be able to manage their issues better, and then really engaging them about, a conversation about how are we doing? How can we do better? What are the ideas that you have as a patient, as a customer, as a consumer of the care that we give that could actually help us make our care better? So that's that model of care that we've been working with since our clinic started getting recognized back in October of 2011, and nothing about this model or this basic structure is going to change in the new standards. Again, Chris pointed out there's actually about 630 recognized clinics in the state of Oregon, which is just, to me, astonishing, amazing that you all in the primary care system in Oregon have stepped up to engage in this model of care. That's about 3/4 of all primary care clinics in the state. You know, a vast majority of coordinated care organization members, folks with Medicaid, are enrolled in care in a PCPCH clinic. This is not just a Medicaid program, but that's an amazing thing just to see that Medicaid population getting their care in those clinics, and may have a lot to do with some of the cost outcome and care outcome differences that we see in that population. When we do look at quality, we can see in the Quality Corporation statewide report, which is, there's a link there to it, that in the vast majority of quality measures that they looked at, something like 13 out of 16 measures, if you get your care in a patient-centered primary care home, your quality of care is better, statistically better than if you do not. So again, that's wonderful to see that the work that you all are doing, that hard work to bring people back in for their care, to make sure that you're giving them great care, really does make a difference. So here's just a map of all those red dots are patient-centered primary care homes in Oregon. Again, 630. I believe we have every county. Is it every county except for 2? We're working on those folks. They're going to apply. We have a couple of folks out of state that take care of patients in Oregon as well, or from Oregon as well. But again, really great to see that spread, and kind of mirrors the population across the state.
All right, thank you, Evan. So this next slide here, this is just an overview of what we'll be covering specifically. We will take a sort of a deeper dive into each specific measure that is changing. We'll give you an overview of the new tier structure, and then we'll describe some resources you can take a look at, as well as what to expect with the 2017 application process. And also, as Kate mentioned, we'll make sure and leave you our contact information at the end of this presentation if you have specific questions. Okay, so one of the big questions, obviously, that folks are asking us, a lot of the questions center around the application timelines. So we kind of have 3 scenarios here, and all of your clinics will fall into one of these 3 scenarios right here. So I won't necessarily read every line on the slide, but basically, one thing I want to mention right up front is that the application system that includes the new, the revised model, the revised measures, won't be available until January 1st. So you won't be able to access it until that time. So the first scenario here is that clinics that were recognized in 2014 and due to reapply in 2016 have been granted an extension to apply January 1st, 2017. This is where the majority of our clinics land. So most of you all will be submitting your applications for renewal in the beginning of the year. Because the application system is actually not available until January, we've given everyone a 90-day grace period, so your applications would not be due until March 30th. So you have some time to work with the new system, get familiar with what's in it. Also, reach out to us with questions you have at that time, and we can help you get your applications filled out and processed. Another scenario is that clinics that were recognized in 2015 have 2 years from their recognition date to reapply or keep their recognition current. So for example here, if a clinic was recognized in April 2015, they would be due to reapply April 2017. So right now this is about 150 of our clinics, and you have the normal 30-day grace period, which has always kind of been the rule of thumb for our clinics overall. And then the final one is that clinics that are due to reapply in January 2017, clinics that were recognized in 2016 are due to reapply in January 2017. So I know that's a bit of an anomaly. So in other words, even if you received your recognition sometime this year, you will need to submit a new application in 2017. So if you submit one today, you're still going to have to apply in 2017. The smallest number of clinics fall into this scenario because most folks are waiting. And then again, you'll have a 90-day grace period to take you to March 30th.
So Chris, it sounds like the first scenario and the last scenario basically, again, you have to apply between January 1st and March 30th. That is almost 500 clinics. And then that middle scenario there is just those other 150 clinics who got their recognition sometime from April on in 2015. Yeah, okay.
So what can you do to get ready? So we have a few resources here for you. Obviously, one of them is the Technical Assistance Guide, which is currently available on our website right now, actually. So even though people will not be able to apply until 2017, everyone is still welcome to access the TA Guide, take a look at what's in there, kind of get a sense of where their clinics stand in regards to the measures and those sorts of things. And certainly, even though you can't apply till 2017, you can still give us a call if you're reading the TA Guide and have some questions and need us to clarify. We'd be happy to help you with that so that you're as prepared as you can be in 2017. One other thing to consider that's related to the TA Guide, I'll skip down to the bottom bullet point here that's pretty important. You can actually also go to our PCPCH website and complete a self-assessment. And so you're not required to do the self-assessment. You don't need to submit that to us. But clinics have found it helpful in determining exactly what level of recognition they might want to apply for. So as you're kind of looking through the TA Guide and determining how you want your clinics to apply, you might want to take a look at that self-assessment tool. It's a really good help. Going back up to the second bullet, on November 17th, we're actually going to have a virtual open house of sorts. So on November 17th at 7:30 a.m., folks can call in and ask us the questions that are on your mind. And so the PCPCH staff will be available to field your questions and help you out with specifics that you might want to get clarity on. And then the third bullet down, PCPCI has online learning modules, and we are revising them to reflect the most current standards, or the upcoming standards for 2017. And those online learning modules will be available sometime in November, so keep your eyes on the PCPCI site and register for those.
All right, so we're just going to dig in and start talking about the different standards and measures that have been changed specifically for the 2017 model. And we'll start right up at the beginning at access. Again, patient needs help and they're calling in. And so in the 2014 model, we had two separate standards listed as 1C0, 1C1 that dealt with continuous access to advice by phone. And the second one dealt with documenting those interactions in the medical record. And what we found really is that if people, because of medical legal reasons, et cetera, if people were having conversations with folks at 10 o'clock, 11 o'clock at night on the phone, then generally it was considered a good practice to then document that in the medical record. And that was actually how we actually verified this measure when we were doing site visits. So the Standards Advisory Committee took that under advisement and decided to combine these two together and just make it a single must-pass measure, which just, again, is the same front part, which is that you provide continuous access to advice by phone, and then the second part is just that you document the pertinent encounters in the medical record. Again, that is pretty much standard of practice for medical legal reasons across the state. The second measure that has been changed in access, and actually each of the meaningful use measures, but we'll go through them, is 1E3, which deals with essentially the electronic portal that patients have and allowing them access or interacting with them that way. And some of you may or may not know there's a meaningful use metric or measure that relates to that. For all of the meaningful use measures, including this one, those have been reduced in point value from 15 points to 5 points. It is a an optional measure, as all of the measures are that are point value, but that did reduce in point value from 15 points to 5 points. Finally, 1F1 deals with prescription refills, which again, many of you would recognize as sort of an access issue. If you can't access your medicines, that's important. And so 1F1 was basically asking clinics if they were interested in working on this measure to track time to completion for prescription refills, the time that it took them to complete a prescription refill. We recognize doing site visits that this is actually sometimes a very difficult task, hard to do, can be very valuable if folks do it and try and improve on that, but difficult. And so again, the Standards Advisory Committee took that under advisement and increased the value of that measure from 5 points to 10 points. Moving on to accountability. In the 2014 model, there were a lot of changes going from the 2011 model to the 2014 model. There were a lot of changes in this this core attribute in accountability. A lot was done that was different. This time around, there are not a lot of changes. There is only one small change, and that is in the first measure, or the first standard of this core attribute. The second measure in there is 2A is basically looking at the core and menu set of metrics and reporting to us about how you're doing on those metrics, things like diabetes care, care for children with chronic issues, preventive care, etc. There's a whole list in the TA guide. Basically, we wanted to recognize, or the Standards Advisory Committee really wanted to recognize that it's important to start measuring things. It's also important to try and hit a benchmark, but it's really critical to make the move from starting to report things to hitting the benchmark. So to actually, that quality improvement activity or demonstrating improvement is very important. And so that was rewarded essentially, or we're trying to reward that as an option for folks to choose as a 10-point measure in this core attribute, where you report on core and menu set measures, but you also demonstrate improvement over time. The third core attribute is comprehensive whole person care, comprehensiveness, and there's a couple of changes in here. We'll start with 3A1. This has to do with preventive services. So this is a 5-point measure. So this again is not a must-pass measure, but an optional measure. And it reads that the patient-centered primary care home routinely offers or coordinates appropriate preventive services based on available evidence. What has been added is a requirement for identifying areas for improvement. So what that essentially means is that the preventive services that you offer, you've compared them to evidence-based standards, and you've thought about areas that maybe there are gaps, or maybe you could widen the scope of the services that you provide or coordinate to really meet the needs of your patient population. It doesn't specify the details of that. That is really up to you in the clinics, meeting the needs of your patient population and looking at the evidence-based preventive care standards, things like the U.S. Preventive Services Task Force, etc., that you use. A lot of the details for this measure are listed in the TA guide. Standard 3C, which has to do with mental health, substance abuse, and developmental issues, has been the biggest change in this core attribute of comprehensive whole person care. First of all, these measures, the 3 measures underneath this standard, are now what we call stackable. So the first one is a must-pass. It's something that you have to do. All PCPCHs must do. And then there is a 10-point and a 15-point measure. If you are doing those both, you can get both 10 points and 15 points, so a total of 25 points under this standard 3C. The must-pass measure, standard 3C0, essentially requires clinics to screen for mental health, substance abuse, and developmental issues. Okay. Obviously, if you only take care of adults, developmental issues are not something that you're screening for. But if you're taking care of children, that is something you're screening for. That is how we've really verified this measure for quite a while and through site visits. And then we also added the importance of not just having local referral resources like maybe a list that somebody keeps in a drawer somewhere, but actually processes to help ensure that if patients do screen positive and they need help outside of your clinic for mental health, substance abuse, developmental issues, that there's a process at your clinic to be able to refer those patients out like you would have for really any other medical issue. 3C2 is revised to emphasize cooperative referral and co-management of mental health, substance abuse, or developmental issues. That really is much more than just sending records back and forth by fax. There are definitions or descriptions that are more involved in the technical assistance guide, and I really would point you to that to get into the details. But really, we're talking about a process where you're sharing information two ways. You're making plans together with, again, maybe it's external mental health about how you're going to change or improve patients' care. It may be things like the mental health folks are prescribing medications and you may need to be monitoring labs, but that you've discussed that and that information is flowing back and forth. And this also includes co-location of mental health services. So they physically occupy the same building as your clinic, but they're not integrated. Those folks are not integrated, so they don't use the same medical record system. There's no warm handoffs with your mental health folks. That sort of thing would be co-location. The third level, or the 15-point level, really emphasizes the integration of mental health, substance abuse, or developmental providers. It used to talk about co-location, and integration is different than co-location, again, in ways that I described and in ways that are described in the TA guide. And really, with that 15-point measure, then, again, you have a behavioral psychologist or somebody like that who is at your clinic, who is part of your team. You're sharing notes back and forth. You're talking about patients. You're doing warm handoffs, same-day warm handoffs as needed. Those sorts of things are going on at the same time as you are definitely still coordinating care outside the clinic when that's necessary. So those are very different levels of robustness of the mental health, substance abuse, and developmental care that you can provide in your clinic. Again, just that 3C0 is the must-pass. These others are optional, but you can be doing all of them and get credit for all of them. Okay, and just one last one in this comprehensive whole person care that has changed. This is standard E3E, which has to do with reminders for preventive services. So reminding patients to get the care that is recommended for their age or gender. And 3E1 now is the meaningful use measure. That used to be worth 15 points. As I mentioned, all of the meaningful use measures have 15 points to 5 points in value. So 3E1 is now the meaningful use measure of preventive service reminders. 3E2 has to do with essentially generating, it's really that quality improvement, patient outreach activity. So using data to generate lists of folks that have gaps in care, and then actually doing proactive outreach to patients for those recommended preventive services. And finally, 3E3 is, again, a more robust version of that, essentially tracking to monitor the completion of those preventive services. So you've identified folks have gaps in care, you've reached out to them, and that final step is that identifying that those folks have actually completed those preventive services. That is the 15-point measure. In the core attribute of continuity, there's just this change here, which has to do with medication. Actually, there's a couple little changes we'll come up on. Changes around medication reconciliation standard. Again, the meaningful use measure that is part of that, you all click the boxes in your EHR for that meaningful use measure. That has now become a 5-point measure instead of 15 points. And then there is a 15-point measure in that standard that is really about comprehensive medication management that will often involve an integrated pharmacist, for example, for folks that have a lot of medications that are prescribed, have significant chronic illnesses that create comorbidities, things like diabetes, chronic pain, etc. And that's, again, an additional optional measure in this standard. Okay, coordination and integration. We're getting close. We're getting close. The first measures in coordination and integration have to do with essentially using your data management system, your medical record system for the vast majority of you, and using it in a way that helps you organize patients into things like age, gender, disease state, things, and then as a result allows you to use that data in some way. And essentially 5A1A and 5A1B in the old model were combined together. It's really has to do with how functionally things work now in primary care into one 5-point measure. I won't go into the details of all that. That is in the TA guide. 5A2 becomes the next measure in that standard, and that has to do with population data management. And this has to do with, this is a 10-point measure that has to do with being able to risk stratify your patient population according to health risks based on health needs or behaviors. So a lot of clinics have done this type of work through the Comprehensive Primary Care Initiative, or CPC. A number of pediatric clinics have done this work. A number of clinics are recognizing the importance of trying to focus our efforts on folks who we can make the biggest impact on with limited resources, and the way to do that is to really risk stratify or decide how risky are patients, how likely are they to have trouble, and where can we intervene. And this measure really deals with that process. 5C1 has changed essentially. This is just almost a wording rather than functional change. We recognize that, you know, as we're doing site visits, and again, the Standards Advisory Committee recognized that in clinics, care coordination activities are different depending sometimes upon the staff that you have there. Sometimes it's one person that's doing care coordination. Sometimes it's several people that have carved out specific roles in care coordination. And so this just changed the measure language from saying identifying essentially one person responsible for care coordination to identifying the people, the team roles, those folks in that clinic that are responsible for care coordination. And that really just gives a little bit more flexibility for the clinics to do this work with the team members they have available. Finally, the core attribute of person and family-centered care. And the only change here, which is a significant one, is in 6C, the standard 6, to do with essentially gathering patient experience information or gathering patient feedback. In the 2014 model, there was a 5-point measure, 6C1, which basically said that you had to survey your patients at some point during your application cycle to ask them about their experience of care. Excuse me, this measure becomes a must-pass measure. So again, it's something that every PCPCH of any level needs to do. And again, the Standards Advisory Committee felt very strongly about this. This was actually recommended by the 2014 Standards Advisory Committee originally, but the new committee felt that, again, this is called the patient-centered primary care home, and we have to have patients front and center. And part of that is engaging those folks in assessing their experience of care and trying to improve on that. So that's why this was made a must-pass measure. It does not say that you have to use a specific brand of survey for this must-pass measure. However, in 6C2 and 6C3, the 10 and 15 measures, those do specify that you need to use the CAHPS survey, the CAHPS survey, and there are a couple of different versions, 2.0 and 3.0 of that. Again, all of that nuts and bolts are spelled out in our TA guide. But those are those are measures that change just a little bit in that we are requiring that you actually use the survey data that you gather. So what we did not want to see, we didn't see as meeting the intent, is if somebody does a survey and then sticks the results on a shelf and never looks at them. But if people are looking at them and trying to use that information in some way to improve care, to assess care, that's what we and the Standards Advisory Committee wanted to see in those 10 and 15-point optional measures. And so that word "and" has been added in there. Okay.
All right, thank you, Evan. So shifting gears here, and this is the last topic that we will cover during this webinar, and then we'll take your questions. So thanks for hanging in there. I know it's a lot of information. As I mentioned, this will be recorded. You can go back and look at it, and also the resources I mentioned will be available to you online. And then certainly, if you've looked at the materials and you're still stumped and need some help, we'd be happy to help you out. So the last topic we'll cover is the tier revisions, or the structure of the point layout. So in addition to specific measures within the program being revised, the tier or point structure is also changing. So the reason it's changing is to continue driving primary care improvement. The initial model was created to sort of introduce people to the concept and get them moving along, and then the revised tiering structure is to continue that progress and to require people to stretch a little bit more. So currently there are 3 tiers in the program, and we are switching to 5 tiers, and I'll give you an overview of what that looks like. And just the third bullet point there, just to highlight this fact for you. So we are changing, the highest level recognition currently is the 3-star, and we're changing that to a 5-star designation, but the requirements are the same, with the exception, obviously, of the kind of the point spread and the layout, and I'll explain that in a moment. So here's the breakdown of the upcoming tier structure. So as I mentioned, right now, the current tier structure is 3 tiers, maxing out at 380 points. So under the new model, the maximum points available will still be 380, but the difference is the point layout is spread out over these 5 tiers here. And so that's the primary difference in terms of the point structure. And then if you go down to the 5-star section of this graph here, or this chart, it's still the same requirements of the current 3-star. But if you'll notice, in order to be 5-star, you essentially have to be a Tier 4 PCPCH with some additional requirements. So for 5-star, obviously you must meet all the must-pass standards. But one of the primary differences is that you have to meet 11 out of 13 specific measures from a menu of measures that you can pick from in order to be 5-star. And the reason we've done this is because these 13 measures that you can pick 11 of tend to produce more robust primary care transformation. And so, and those specific measures are also listed and available on our site. And then finally, one of the main distinctions of becoming a 5-star is that you have to have a site visit in order to be recognized as a 5-star. So to contrast that for you, right now, kind of the regular tiers is attestation based, and so you fill out your application, we review it, and you become recognized based on what the materials you've given us, and then your clinic will have a site visit in the future so that we can verify that you all are doing the work that you attested to in the application. The difference with a 5-star is you are required to undergo a site visit prior to being recognized as a 5-star. Okay, so that is the material we wanted to share with you, and we would be happy to begin opening up to questions that you might have.
Okay, great. So as a reminder, you can type your questions into the questions pane in the GoToWebinar control panel, and we'll happily take them and read them for the presenters. We have a few queued up. So I'll start with the first one. Could you just reiterate again the application deadline timeline for, and specifically related to people who attested in 2015, and then clinics that haven't yet applied?
Sure. Yeah. So I will, just quickly give you a little bit of a recap on the application timelines, and certainly we'd be happy to share a kind of a written summary for folks also, so they can have that in writing. But the bulk of our clinics will need to reapply in January 2017. So, for example, if a clinic was recognized in 2014, they will need to reattest in January. But there's a 90-day grace period, and so you would have until March 30th of 2017 to get us your applications. And so, as I mentioned, the majority of our clinics fall under this category. Another scenario is that if you were recognized in 2016, in other words, if you submitted an application and became a PCPCH in 2016, again, you'd be required to apply at the beginning of the year with a grace period taking you to March 30th. And the final scenario, which is about 150 clinics fall into this category. If you were recognized in 2015, your application, or excuse me, your recognition is good for 2 years from your recognition date from 2015. So I know there are a few different timelines here, and that can get confusing. So as I mentioned, we'd be happy to send you this kind of in writing, or you can also go back to the webinar slide once this is recorded and available for everyone to get the layout of where your clinics might fall.
Great. There's another question that's specific to 1A, which starts on page 14 of the technical specifications guide. But what period of time do people need to benchmark, and how many months do they need to meet the benchmark? So could you talk a little bit about the benchmark related to that standard?
Sure. Generally, we're looking, so CAPS has specificity, and you're looking at, depending on which version of CAPS you use, you could be looking at different amounts of time that they're looking at benchmarking. So that's where some of the confusion may be. I wanted to say that CAPS is not a requirement for everyone to do. So the must-pass measure, and we're talking about 1A, but there's no must-pass requirement to use CAPS. The CAPS measures are all optional measures. So generally, we're looking back a year or 2 years, but there's also the CAPS 3.0, which is actually a 6-month look back. So it depends essentially which survey you're doing. Now, if you're using a non-CAPS-based survey, we're looking at an annual evaluation, essentially, right? That you're going to do. But it really does depend on what survey tool you're using to ask about access. That may have been a clear as mud explanation, but again, CAPS has specific rules, and the specific rules of each CAPS version are different. And if you're not using CAPS, then we're essentially looking back at the last year of time, and for certain CAPS versions, that is also true.
Okay, great. And then someone had a quick question, and just we can say that the self-assessment that I think it was Chris referred to that clinics can use is updated for the 2017 standards. So that was a quick one. Next question is, can you compare the previous point structure in 2015 versus 2017? Specifically, the difference between a tier 2 then and now, and just where some of those differences are?
Sure, yes, and also related to this, because that's an excellent question, and certainly I understand, folks are trying to wrap their minds around what was or what is right now, and then what's upcoming. So right now for tier 1, the point spread for tier 1, let me double check here before I say it, is currently the same for tier 1. So that would be 30 to 60 points. Tier 2 is also the same. So tier 2 is 65 to 125 points. And then, yeah, tier 3 is 130 and above. And then tier 4, tier 3 is, the current tier 3 is 130 to 250. And then the new tier 4 will be 255 to 380.
Right. So tiers 1 and 2, and the Standards Advisory Committee did this on purpose. They didn't want people in tier 1 or 2 in particular to drop a tier. They wanted to give them a ladder to climb rather than requiring them to drop. And so tiers 1 and 2, that point spread is unchanged. It's tier 3, which used to run from 130 points to 380 points, an enormous spread that has been split into more than one tier.
Great, thanks for that. There's a question that has come in about NCQA. So for a clinic that is already NCQA tier 3, what does that mean for PCPCH recognition?
Yeah, so almost all of the NCQA clinics, well, generally, historically, the Patient-Centered Primary Care Home Program has recognized NCQA clinics as doing significant work. And so clinics can use their NCQA application to essentially qualify or apply and qualify for PCPCH recognition as well. There are a couple of differences. For example, NCQA does not have a must-pass standard around end-of-life care, for example. That's just one example. There are a couple little data pieces that clinics have to submit, but essentially they're using their NCQA application to get PCPCH recognition. That being said, the vast majority of them actually take the time to go through the PCPCH application because they would like to say what they've done. And so they don't just use that NCQA application. They usually go through and actually tell us the things that they've done. That is a voluntary process. At this point, NCQA level 1, 2, or 3 would fit with PCPCH level 1, 2, or 3. And if clinics wanted to be a tier 4, they wanted 5-star designation, which again is a completely different application and recognition process. They would need to indicate that and fill out the appropriate application materials.
Yes, and just to elaborate on that a little bit, thank you, Evan. And so we don't encounter tons of clinics that are NCQA recognized as we do site visits, but for those of you on the phone or listening to this presentation later, for those of you that do have NCQA PCMH recognition, you can use, like as Evan said, you can use your NCQA levels 1, 2, and 3 for PCPCH recognition, and so that would give you kind of a different track as you're completing your application, and then just make sure you indicate that on your application. There are actually buttons and options to indicate that as you're applying, and so if you wish to do that, make sure you do so on your application. But as Evan mentioned, if you want to be PCPCH Tier 4 or PCPCH 5-star, NCQA would not meet those needs.
Okay, great, thanks. And then a couple of back-to-back questions related to patient surveys. So the first is, we see pediatric patients but only use one type of survey. Is that okay? And for practices in that situation, do we need to report or meet benchmarks for both pediatric and adult populations?
Great question. I guess I might... So this is a family medicine practice, it sounds like, that sees pediatric patients and only offers one type of survey. You know, there are pediatric or family versions of most surveys. So if there's a CAPS survey, there's adult CAPS, and then there's the pediatric CAPS, which is given out to the pediatric side. Generally, we would ask that you're assessing care for your entire population. With this specific question, it might get down to the details of, how many kids do you take care of? What kind of percentage have you thought about actually doing this? And I guess I would ask people to stretch a little bit in this. If you're assessing your patient experience, that means you're assessing your patient experience for the scope of patients you take care of. And these tools have pediatric versions, they have adult versions. That's my clinical side speaking there.
Great, and then there was a question about whether 25 surveys are required for a must-pass, or could you speak about what's required for the must-pass? And then I'll just go ahead and read the other survey-related one now, which is that there's someone who said they're using survey questions from CAPS, but they're not using the tool itself, and how should they count or address that?
Right. So generally, I would just, especially around surveys and things like this, so many details and little things and individual situations, I would definitely refer you to the TA guide as your first step. So all of this information should be in here. So for example, to meet 6C0 listed under there under the bullet points, 50% of the survey questions must be answered for the survey to be considered complete and to count towards 25 surveys per provider minimum requirement. Clinics must obtain survey results for a minimum of 25 completed patient surveys per provider each time the survey is administered. So it really does lay out the specifics of the measure, of this must-pass measure. Again, for the must-pass, you do not need to use CAPS. The person that asked that is using some CAPS questions, I guess, again, I would say why. And second question would be, well, that probably, if they were asking the right questions, and we don't know, the details of that might meet that must-pass level. It would not meet the CAPS-specific measures, of course. But again, these things are laid out pretty in some pretty good detail in the TA guide. So I guess just take a look at that, read through that, and again, we have these office hours coming up and the PCPCH email, etc., that we're happy to answer more specific questions, but it's hard for me to get more detail than that.
So I was just kidding about the survey questions being over. There's actually two more. It's you mentioned 1 year of data for patient experience, but if a clinic's just now implementing surveys, do they have to wait till they've been surveying for 12 months? And then also going back to clarify something earlier, for practices that are continually surveying, the 75th percentile changes each month as practices get better and worse, and how do they address that as it relates to the benchmark?
Great. Yeah, again, when I'm talking about 6 months or 12 months or things like that, and that's why the detail is so important, that has to do with how far you're looking back and how far, essentially what you're looking at, what you're asking people the patients to address. And so generally, when clinics are doing survey work, even if they're a new clinic, we ask people to collect a year's worth of information, but we do ask them to, in certain circumstances, if they can demonstrate that there's special circumstances, sometimes the program will accept 6 months, but it has to be a conversation. And so what I would say is, yeah, if you're just starting to do the survey now, I wouldn't attest to doing the survey and like meeting benchmarks, let's say, based on your first month's worth of data, because that wouldn't meet the measure. Again, you're going to be good on the must-pass part as you're doing that work, but with a month's worth or 2 months worth of data, you can't meet the benchmarks because that's how the specifications read. There was a second question to that, Kate. What was your second question?
It was, sorry. So the second one was for folks who are continually surveying. They are meeting the benchmark and maybe not meeting the benchmark as those results change. So they're unclear about how many of the past 12 months they're supposed to have met the benchmark.
Good question.
I know, I thought so too.
Yeah, basically, again, you know, we're asked, this is a self-attestation program. You guys in the clinics are going to be tracking this data, and at some point you're going to attest to meeting these things. If you have data that's sometimes above the benchmark and sometimes below the benchmark, and it varies, and you don't really know that you're really hitting the benchmark, then don't attest to hitting the benchmark. Try and improve on it, which is the other level, right? So that's the 10-point measure, is to try and improve and demonstrate improvement instead. If you are above the benchmark every month, except for 1 month it happens to dip down and then it jumps right back up, again, on average you are meeting the benchmark. You're doing fine, but it's a self-attestation program. We're asking you guys to make the call, and to not make the call, you know, your goal is to try and improve patient care. And if you're not sure if you're meeting the benchmark to improve patient care, then you should work to improve it, and you'll get credit for that. But don't say that you're meeting the benchmark if you're really not sure. That would be my advice.
Okay, thanks. And then I just let anybody know, we have a few more questions that we'll go through. If we either don't get to your question or you still have some lingering thoughts and doubts, you can either connect with us over the office hours time, or we also know who asked which questions and can follow up with you one-on-one for some of the trickier ones. Changing topics from surveys, can multi-site practices attest once, or do they need to attest by site?
This is a great question, and one that we get periodically. So the answer is each site, even if it's part of a medical group or a larger health system, each site must submit its own PCPCH application, because when we do site visits, we site visit the specific clinic location and assess that clinic on its own merits.
Yeah, what we found is no matter, we've been to every health system in the state, we've been to small clinics, big clinics. Clinics are not all the same, and even within a health system, they are definitely not all the same. Whether or not, you know, people believe that, it is true, and it's dependent on the population they serve and the folks that they have in the clinic and what they're doing in the clinic. And since the beginning in 2011, this program has recognized the clinic level of activity, not the organization level of activity.
Yeah. And sometimes it's actually a good opportunity when we do visit a larger medical group or health system to go to one of the clinics, and then through the process of a site visit, you know, folks discover that they don't all do things the same way, even though maybe on paper it looks that way. And so it's an opportunity for the clinics to learn from each other.
Yep.
Okay, great. And then is there any advantage to submitting an application now versus in 2017?
You know, it's totally up to each clinic. I mean, I couldn't speak to everyone's situation. I mean, the one potential scenario I could think of, which certainly would be on a case-by-case basis, if a clinic is receiving, you know, some sort of incentive for being PCPCH recognized and they're currently not recognized, you know, that could be one scenario where they would want to. But from our program perspective, there's no drive one way or another at this point in the year, since the standards will be new in 2017. And so I would encourage folks, if they don't have some sort of other driving factor, I would encourage them to become familiar with the measures right now and begin to look at how they might want to attest in 2017.
Great. And then we have two more that we're going to get to, and then I think after that we'll have to take them by email or at the office hours session. So other than being recognized, is there an incentive to pursue Tier 4 or 5-star?
Yeah, great question. Certainly, you know, being recognized is important. Doing the work is the most important thing, regardless of the recognition. But where it comes down to nuts and bolts is there are some, well, I would say many coordinated care organizations that pay based on tier level. There are private insurers that pay based on tier level. All of those folks are going to adapt their payment mechanisms to this five-level model. This is PCPCH is still a CCO incentive metric, so CCOs are still going to want folks to really be recognized. And so what we see is that folks that are tier 4 or 5, 5-star, are really doing great work and feel good about themselves. But the other place that it comes across really, if you're 5-star, you're advertising that to your patients and saying, look at the great care we give. And the current 3 stars are proud of that, not just internally, but externally to their patients, and really use that as a marketing strategy for businesses and for other patients to in their community.
Great, and then the last question, is there any way that the application can be viewed before January 1st, or are folks needing to wait until January 1st to even have a look at it?
Right, good question. So the online application system will not be live with the revised standards until January 1, 2017. So there's not an opportunity to go into the application system and sort of explore that in terms of the new measures. But I would say the next best thing potentially would be for folks to look at that self-assessment tool we mentioned a little bit earlier in the presentation, and it'll give them a good sense of what the measures are, what kinds of questions and materials they would need to answer and provide, and where to go from there.
Great. I know lots of folks probably have somewhere to run off to, so with that, we'll go ahead and close. If you didn't get your questions answered, there's contact information on the slide. I also put into the chat the registration link for the office hours Q&A webinar that we're going to be hosting here in a little bit. And then we will also be emailing a link to everyone who was on the webinar today to the recording and the slides. They'll get that sometime later this week. And we appreciate everyone's time and hope you have a good rest of your day.